It's my pleasure to introduce Dr. Lowell Anthony. Dr. Anthony is the Chief of the Division of Medical Oncology at the Marquis Cancer Center in Lexington, Kentucky. He has more than 2 decades of experience in oncology and a special focus on neuroendocrine. He also has a focus in gastrointestinal oncology. His clinical interests include drug development ranging from phase 1 to phase 3 clinical trials, agents targeting specific cellular signaling, I have new teeth, people, excuse me, signaling pathways and injectable radio-labeled compounds make up his past and current clinical investigative interest. Dr. Anthony attended Vanderbilt University Medical School, where he also completed a medical residency and fellowship training in medical oncology and clinical pharmacology. He has previously been on the medical facilities at Vanderbilt University and the Louisiana State University Health Services Center in New Orleans. Dr. Anthony is a fellow of the American College of Physicians. He is an active member of several professional organizations. He has served on committees with the American Society for Cancer and with the American Society of Pharmacology and Therapeutics. Dr. Anthony is also listed among the best doctors in the U.S. for the past 6 years. On a personal note, I want to add that Dr. Anthony is my physician. I'm very pleased with him. He's just an amazing, amazing man, and his staff is amazing. And it was a great pleasure. I turn the microphone over to Dr. Anthony.
So it's a real pleasure to be here, and thank you, Paula, for that very kind introduction. So the problem when you deal with someone like me and Eric is we have a passion, and we have a tendency to be overly enthusiastic, maybe. We have to sometimes have restraints held on us, but I think it's all in a good way. Well, I think when you were in that jacket, when the police, oh, I'm just kidding. Nobody has seen those pictures, okay? So you can't do our business without working with industry. My bias is to work with all industry and try not to be partial. Okay, so a number of years ago, it evolved out of somatostatin story and seeing tumors shrink, which is small, very small group with somatostatin. I knew by 1992 this was going to be a career, and I had to kind of figure out how to negotiate through the maze of complexity when you deal with a rare disease. And that's really the story that I started seeing in the early 90s, and it took me until about 2016 to put this together. I wanted to do this in the early 90s, but for a rare disease where the major diseases at the time were not organized to this extent, and the resources could not be put behind me, and I won't go into all the details on specifics, but moving to Kentucky in 2011, Mark Evers, who basically was the person that described the first in vitro cell line and in vivo cell line in animal preclinical model, having him as a cancer center director, I knew there that I would not have to justify and compete for resources for rare disease. He got it. Basically, cancer center director, senior leadership, got it. You know, that's what it really takes. So what I'm showing this slide is to see that clinical trials is central, absolutely central in us advancing the science. I'm going the wrong way. When we think about treating neuroendocrine tumors, we think about drugs. We think about somatostatin analogs as being the background or the backbone of this management, of this treatment. The analogs are octreotide was first, lanreotide was second. The depot formulations came subsequently. Serotonin inhibitors are critical in lowering serotonin levels that I'll talk extensively about. mTOR inhibitors, you've heard a little bit about everolimus, afinitor, the PKIs, the tyrosine kinase inhibitors, just things to go over, just to have them start rolling off your tongue. Sunitinib, a drug approved for pancreatic neuroendocrine tumors that we may also use in lung. Capecitabine, and temozolomide, we call that CAPE-TIM. I'll talk about the development of that regimen. Local regional therapy. This is critical in controlling the disease because in the liver, this is where this disease really dominates. And then peptide receptor radiotherapy, an exciting era of future development. When we think about cancer treatment in general, a class of drugs that comes to mind right off is biotherapy. For application to this disease group, interferon. So by about 1978, alpha-2b interferon was shown to inhibit carcinoid syndrome. This is all related to the work done by Kjell Oberg in Uppsala, Sweden. And because it happened there, because of the way their health system is structured, but he also had access to interferon through the Finnish Red Cross in Helsinki. So it was geography and healthcare organization. But what's interesting just within the last week or two, I received a letter from Merck basically informing me they're no longer making alpha-2b interferon after 40 years. Whew. Isn't that amazing? So does that mean that somatostatin analogs have about a 40-year period? You know, got another 10 years there. I doubt they're going to go away in 10 years. But our goal, if you really look at our goal, is to have everybody off somatostatin analogs, cure all this disease, surgery, any kind of therapeutic intent, immunology, get the immune system involved. If we can get people off the somatostatin analogs, maybe that's the way we can get rid of them. But not, basically, I don't think the way Merck did it. Drugs just not of any interest anymore. It was approved for neuroendocrine tumors in Europe, but never approved in the United States. Chemotherapy. Who wants to hear about chemotherapy? Not too many people. You know, this is toxic stuff. Well, you've got to put it in perspective. We've got IV chemotherapy that can be very toxic. And we've got oral chemotherapy for this disease that really I call it more chemo-light. People don't lose their hair. You don't get the myelosuppression necessarily. You don't have the nausea and vomiting that we see with IV chemotherapy. So not all chemotherapy is the same. Targeted therapy. This is really the reason I went into oncology, was somatostatin was targeted therapy in the 1980s when it came out. It was targeted therapy. So I went from a world of giving chemotherapy in my training where people, if they saw me in the grocery store on weekends, they would vomit because we didn't have good nausea and vomiting drugs. They were conditioned to me giving toxic therapy. So I lived through that era of supportive care where we developed oral antiemetics through clinical trials. And I went into hormonal therapy that same decade, targeted therapies, and my language did not communicate with my colleagues at Vanderbilt. They talked cytotoxic chemotherapy. I started talking about hormonal therapy. In prostate cancer, it was coming along too. So I came in as the hormonal therapy for prostate cancer was also gaining steam. Radiotherapy, PRT, we can say that's the ultimate somatostatin analog as it relates to targeting radiation to the tumor cells. Where are we headed? The fourth class of drugs now, or the fifth class really, if we look at biotherapy and hormone therapy is separate, we're looking at immunotherapy because this is going to be the future of how we harness the immune system to do what Dr. Liu can't do, and that is to get rid of every cell. He can only see what he only get rid of what he can see. So if you think of this disease as being an iceberg, what's below the surface is what we worry about. We can see what's above the surface, but what we don't see is what we're afraid of in terms of how big is it, if at all. Ideally, if the surgeon can remove everything they can see, maybe you're lucky that the iceberg below is very small, if not at all. But we know that it's going to take more than chemotherapy and surgery to actually cure. And I'm going to focus a little bit on antibody-drug conjugates. We do have some pharma, and we have partnered with industry to develop where we, instead of using radio-labeled, we have a target of a non-radio-labeled product, and this is coming along. It's already there in breast cancer, and it's coming along in other areas as well. Okay. The Moonshot program gave us a huge burden, or a huge target, a hurdle to jump over. So you can say that the burden of oncology was not realized when the Cancer Center Trial Act was created in 1971 by President Nixon. That's what created about 30 NCI-designated centers. Where are we after 40 plus years? Where are we with that? Well, the Moonshot program attempted to, again, challenge us to rethink how we work together, to communicate, to get out of these silos. And so the initiative here through this clinical trials working group is to advance the science across institutions, between the government and the companies and the investigators, all parties. So if we look at drugs that are in development, this is 1,100 medicines and vaccines that are in clinical trials now. There's about 3,100 out there. So there's another, so this is again like the iceberg. We can see 1,100. There's another 2,000 that are sitting underneath the water that may launch forward. And this is what really keeps us waking up in the morning wanting to go to work. Why do we do clinical trials? Establish a new care, establish a new standard, because we know the current standard may not be good enough, is not good enough in many settings. We want to answer specific questions, and these questions could be in therapeutics, and I'll show you a good example there, prevention, in screening, and in diagnostic. Participants have the opportunity to do things that are beyond what's normally requested through standard of care. You learn about yourself. You do things like patients up in clinical trials will go get an EKG. Oh my God, we didn't know something. We got just a simple EKG the clinical trial said you had to have. We learned something. Something simple. Oh, we checked some blood level that we normally wouldn't check, and we have to sort of put that in perspective. And with this, we can contribute not only to the knowledge of that individual, but also gain information across a larger disease type. So now if we look at U.S. cancer mortality, and these are males and females across a 34-year period or so, 30, 40 years, we can see that the mortality has been fairly flat. If we look at ALL as an example of where advances have been made, in the pre-1970 era, this was pretty much a death sentence for children. And as I graduated from college and went to Hopkins for a year and a half, I started hearing about advances in ALL by about the mid-70s, and it was like, holy Moses, you know, this really advances being made. Little did I realize that it wouldn't be very long that we would see improvement that were transformational. So how do you think this happened? Participation in clinical trials. And this is where in ALL, 85% of the eligible children were participated in osteosarcoma, those nearly a little over half, neuroblastoma, 3/4. When we translate this to the adult world, we go from a tremendous number of participation in children to a very low number in adults. This is something the NCI is a bit frustrated with. They've put our target around 10%. They always double what you can probably achieve, but this is where we are. How are they conducted? Well, they're conducted in different phases. The earliest phase is safety. We can say first in man, first in woman, first in human. What exactly is going to happen? Those drugs that make it that far along have been extensively tested preclinically. If they make it through that, they'll go into efficacy trials. How good is it? And that will give us more data across disease types. And then if we really now see a promise and opportunities, it'll move into where it's going to move the needle of standard of care. It's going to take it from whatever it is to some portion going forward. We'd like that to be a tremendous step. But unfortunately, a lot of clinical trials in oncology are tiny baby steps. And then post-marketing, once a drug's approved, the industry is required to do post-marketing surveillance to see what the safety is. The FDA doesn't really get, they want a drug used in at least 1,000 people before they'll approve it. These are just rough numbers. Once it gets into 1,000 people, they want to see safety in 10,000. And once a drug has been given to 10,000 people, things that could happen additional above that would be minuscule, be rare. So you can kind of see drug safety and how human participation is required. So how do we come up with clinical trials? Where do they originate from? Well, the parties that are involved, I'm going to sort of start with this example, started in a basic science laboratory at Columbia. The school where Dr. Liu, I guess he's left now, he's got probably a surgery. I think he was called to emergency surgery. Is he on the staff at Vanderbilt still? But anyway, in Dr. Liu's former institution, there was an investigator there, Robert Fine, F-I-N-E. You'll see he's the second author here. He did some work with cells, Neuroendocrine cells in his lab. And he found that an alkylating agent called temozolomide, a DNA inhibitor agent called 5-FU. He could use these drugs and see an impact in neuroendocrine tumor models. It's pretty phenomenal. And I actually met up with him during one of our basic science posters a number of years ago. He comes to me and says, Lowell, I want you to do a clinical trial of capecitabine, temozolomide in neuroendocrine tumors. I said, well, who's going to pay for it? Well, I don't have anybody pay for it. Well, I guess I have to get my institution to pay for it. Well, you know, institutions really aren't in the business of paying for clinical trials. They're not in the business of what pharma does. So we said, well, what about if we go to pharma? Well, pharma's not interested. Oh, they're not interested. Oh, really? Well, let's get the government involved. Well, the government comes along and says, well, pharma can at least donate the drug. We can't support it. So everywhere Dr. Fine turned, no, 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 no. That's the early story of my career. I can tell you projects, ideas that I had everywhere I turned. No, 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 no. We get used to saying no. We get used to hearing no, never stops. So there was a gentleman, Jonathan Strasberg and Larry Coles, the senior author here, at Tampa. They were seeing us quite a few of these people, and they were able to just force it down insurance companies to pay for it. How they did it, I don't know, but they did a single center trial, and they standardized it. And you can kind of say they cheated. You could. They didn't go through the FDA. They didn't declare a formal protocol. They didn't do X, Y, Z. They just said, we're going to try it. They did it. And lo and behold, this is what they saw. Whenever the bars go below 0 here, the tumors are shrinking. When it goes below the dotted line, people jump up and down and say that's significant. That's a partial response. That's what we want to see. We want to see a complete response. But anything below that hits 20% or more, that's exciting. And here you can see the actual scans that they publish. So this is patient A, patient B, patient C. Before, after, before, after, before, after. That doesn't look like anything like that. So even a surgeon could look at these scans and see improvement. Now, all the surgery in the world is not going to get rid of all these melon balls. Is that what we call them, Eric? All the surgery in the world. You need a liver transplant. Okay? Liver transplant's not a good option here. You know, when we see this kind of data, this was like 2/3. The incidence of this responding was about 2/3 of his patients, the majority of patients would, and you can see back on this waterfall plot, you can count the number of people below this, but even here the disease could be controlled. It's just not shrunk. This was really quite exciting. And this is what we call the overall survival curve. You can see here people staying alive. In the progression-free, we can see that the tumors will potentially grow at some point, but it took 18 or more months. So you're having a difficult disease, nothing else can be done, we can shrink a significant number, and then it takes 18 or more months for the disease to progress in half or more. That's pretty powerful. So what do you think happened after that? They publish it. Now the government, the NCI specifically, has to do a cooperative group trial. They're forced into it. It's a shotgun wedding. They have no choice. So the trial design was the combination versus a single agent, temozolomide. So this is just where resources all of a sudden appeared. And this study was reported last summer in 2018. And it was really quite dramatic when we see data now that scientific, it goes from the test tube to a single center retrospective review, Strasberg and Coles, and then goes prospective, multi-center, randomized, and you have the science. And this is basically what they saw, and I'll have to go through this kind of quick. They saw a 27% objective response rate with the temozolomide alone, and only about a third with the combination. So the data that Dr. Strasberg got, cut it in half. That's typical. Any institution, you cut the response rate in half when you start getting it out. Now, why that is, it's repeated time and time again. MD Anderson got that reputation in the 80s, that they were always overstating their results. The bottom line is when you get it out of a single institution and you start getting it into users and people that aren't as skilled or developed it, it's going to act a little differently. The median progression-free survival, 14.4 months versus 22. Look, this is pulling away. This is really nice, the combination. So the median overall survival, 38 months with him, not yet reached with the combo. So now we've got data that insurance companies, and we can look at the NCCN guidelines now, can look towards to pay. So solved a problem where industry was not going to solve it, government wasn't going to solve it, started in Dr. Fine's lab. Now we have it for those who need it. Clinical trials is how that happened. We're always concerned about safety, and thrombocytopenia is a thing that we have to be concerned about, but we don't see a lot of nausea and vomiting and myelosuppression and bleeding and sepsis and those kind of things. These are all complications that medical oncologists are used to dealing with. So when we start thinking about clinical trials, cancer chemotherapy here, we have to segregate and be thinking about what the different groups are. The high to moderate Ki-67, the pancreatics, including the poorly differentiated. And here you can see we've got this regimen. This came to us in 1982, streptozotocin. We don't use it anymore. I don't think I've written a dose of strep in maybe 35 years. I was still at Vanderbilt. I think I had to have it co-signed by attending. It's probably one of the worst drugs that we've had. MD Anderson got behind it, and I think they still use it a little bit, but I think the rest of the world's dropped it. 5-FU anthracycline. So these are the drugs that have shown activity and have some recognition through clinical trials. But we're limited. The current status is we're non-curative. We do see refractory disease, we see rate relapses, therapy after surgery when all visible disease or adjuvant trials has not been established. And that's a very difficult thing to do with a disease. It's going to take years and years potentially to come back with treatment or without treatment. So that's kind of where we are in terms of traveling through the treatment. And so how do we go about, when you start thinking about clinical trials, what are some of the things that you ought to be thinking about? What are options? How do holistic or alternative therapies become standard? Really through the same mechanism, but maybe a little different. And this would be where the clinical trial research required and has to have humans. We want to improve new treatments, and then the final step would be where it would start with some concept and then end up being in practice. Where are the clinical trials now in the U.S.? This map is about 6 months old. And if you can see, about every state in the union has some degree of a neuroendocrine clinical trial going. Some more so than others. The different phases we've talked about. Finding a safe dose takes about 30 or so patients. In that, the phase 2, seeing if it's active, that's the phase. We try to get that done under 100 people. And then once we get into phase 3, we're talking about hundreds. And then post-approval would be thousands. Why is it done? Why should the study treatment be better than the current one? How long is it anticipated before you'll be in the trial? What kinds of tests and therapies are involved? How will I know if the treatment is effective, et cetera? And these questions are, you can go to Bob's website, and he's got them listed, and you can use that website as a taking notes and understanding these questions. How long do I have before making up my mind? There should be no pressure of getting into a clinical trial. Is there someone I can speak about before and after, during the clinical trial? Who's the person in charge during the clinical trial? Can I talk to someone who has been in the trial? What are potential side effects or risks? Benefits to me? How do these potential risks and benefits compare to other possible treatments? How will my health information be protected? What happens if I decide to stop? Will I need to pay for any of the treatments or tests? Will my health insurance cover these costs? Who will pay if I'm injured in the trial? Is there anyone who can help answer questions for the insurance company? How will the trial affect my daily life? How often do I need to come to the center? Are there overnight stays? How long? If so, how long will I stay? What are the distances that I have to travel? When are the checkups after the trial? Are there other treatment options, including this one, that are considered standards? And this is a question that we always get asked by our institutional review board. What will happen if I don't undergo further treatment? How does the treatment I may receive in the trial compare with those other choices? And then these are all questions that if you go to clinicaltrials.gov, and this is fairly simple to query, but you could get a very large output. So you have to be fairly specific, because they're going to list every trial. You can see that map that I listed. I think there's like 1,500 or so. You got to be very careful, because a lot of them may not be relevant to you. They may be capturing neuroendocrine carcinoma and other things that are not relevant. So it may help if you're not real sophisticated in searching databases to get help. They do have an advanced search characteristics on this that can help you. And then if there's a pro advocate, even at an NCI designated center, we've got people that will help people through the maze of trying to understand what trials could participate. And so what we're trying to do is finish up this trial right now. There's a Cabo trial. It's opened in about 191 centers. It's going to be a substantial, we think, advance in treatment. And so if any, right now, from a therapeutic standpoint, I want to basically just say that this is something we're trying to finish up. And I'll just put a little plug in for that one. So now I'm going to kind of move on. Now, I've told you what happened with Dr. Fine. So now I'm going to kind of tell you what happened to me. My opportunity to do clinical trials has been just it's been recurrent. There's always a clinic I can identify a problem that I need to solve. And in this particular one, my history started with nausea and vomiting, because I didn't like that person vomiting when they saw me in the grocery store. So I worked very hard in the 1980s on antiemetics for antineoplastics, and I've got the publication to show for it. I just hooked up with Memorial Sloan Kettering and opened a clinical trial at Vandy. That's all I did. So that was a supportive care trial. As a clinical oncology fellow at Vanderbilt, clinical support trials were looked at as wimpy, right? But if you don't control the nausea and vomiting, guess what? People don't show up for their treatment. So supportive trial gives you the infrastructure to move. So now I want to talk about these goals. We want to control the symptoms of disease. We want to control treatment-related side effects, and we want to be sensitive to the psychological, social, and spiritual problems that a disease or treatment can be. So this is the areas where clinical trials can also work, not just curing cancer, but also providing that. So let's just take a problem, flushing and diarrhea. Have we solved that? Have we solved it with somatostatin analogs? Have we solved it with PRT? Have we solved it with surgery? Have we solved it with telotrestat? Have we solved that problem? No, it's still a problem. Still a problem. So what happens if we don't do a good job with controlling the syndrome? We have to be thinking about carcinoma heart disease. Higher cost. People with carcinoma diarrhea have higher cost. 1.5 times is what's been estimated. And they have a twice incidence, hospitalization incidence, and that's going to drive the cost. Decreased quality of life. This is a significant problem, despite 30 plus years of work. So neuroendocrine tumor diarrhea is much larger than carcinoid syndrome diarrhea. Carcinoid syndrome diarrhea is just listed here. Okay, that's somatostatin analogs and telotrestat, local regional therapy, PRRT, surgery. You know, that's what can help that. We have to be careful that those treatments don't cause problems. We know that somatostatin analogs induce steatorrhea, and that's the next problem on the list, drug-induced or surgery-induced, when the pancreas is not secreting enough enzymes. And just replacing it with enzymes is not always simple. Shortened gut. Thank Dr. Liu. He saved your life. He has saved your life, but he's given you a short gut in some cases. Now, in all fairness, what Dr. Liu does, what he does is he measures out what he's going to remove, and he determines whether what's left inside is compatible with life or not. Very, very sensitive to the short gut. But when you lose your ileocecal valve, what happens, Eric? How about a little dumping? A little dumping. Everyone knows what dumping is? Dumping is what gastric bypass patients experience. You eat, 30 minutes later you're in the bathroom. That's dumping. In the gastric bypass, that's what they want. That's the desired effect. In our post-ileocecal valve resected people, it's not what we want. Bile acid colitis. The colon is not meant to function without the ileocecal valve in place as efficiently. And that's because the bile acids will come along and cause a colitis because the terminal ileum, the last portion of the small bowel, absorbs those bile acids. So now those bile acids hit the colon doesn't like it. So the colon gets inflamed, and what happens? It doesn't do its job. The fluid runs out. Bacterial overgrowth. Another problem we have to consider. So you can see that the complexity of neuroendocrine tumor diarrhea is more complex than one single etiology. And this is where the therapist that you go see, I'll be shocked because in medical oncology practices, this is considered a nursing problem. Okay? It is. Eric, in your practice, is this a nursing problem? Do you really want to hear about your patient's diarrhea? Do you really want to hear about it?
How much do we talk about diarrhea?
Okay. You see, that's where Eric and I are. That's where we are. Our spirits commingle, because that's our passion. That's our focus. And he should have said that, or I was going to fire him or something. But I can almost tell you, in a medical oncology practice, and you can speak for the surgeons, that's the last thing my colleagues want to hear about, because they're interested more in terms of what the tumor's doing, more in terms of the therapeutics. Oh, we can take care of that diarrhea. Just throw some Imodium at them. That's trivial. Just throw some Imodium at them. Just get that over-the-counter drug. Yeah. Don't bother me with that. That's, if you don't have a problem, your primary care doc will take care of that, right? Okay. I'm going to introduce a concept. We had an opportunity of learning about a medical food. So what happens? You read the scientific literature. Nature. Nature is one of the most prestigious journals out there. In their scientific reports a few years ago, they reported on this oral amino acid in an animal model of affecting GI health in animals. And this was specifically looking at proliferation. In these animals, they showed that if you look at radiation and saline, and radiation with an amino acid mixture that was just chaos, just put together anything at random, and then they had a very specific amino acid mixture, and they can see where the ones that just saline or the random amino acid mixture didn't do as well as they went out, and then survival for this group did not do as well as all. So the survival here for the saline, here for the random amino acids here, and if you control the side effects of the treatment, the animals can live. That's what that's all about, is safety, is controlling side effects. Okay, so what do you do? So what I did was to call the senior author, this guy right here. What I did in 1980s, I called Richard Gralla for metoclopramide at Memorial. In the 2017, I'm calling Dr. Sagar at University of Miami. And I went down and actually spent a day with his lab, understood what he was all about, and said, look, we need to advance this. And this was a product that he developed. This is not coming from industry. This is coming from a basic science lab, heavily funded, NIH, Army, NASA, multiple funds. And he put together that amino acid mixture for us to test. And this is we're all skeptics in this world. So when I learned about this, I was convinced that it would not work in my patients. I showed you a half dozen or more causes of diarrhea. And I looked at that paper and said, you're telling me we're going to use amino acids and we're going to reverse this very complex thing? You're nuts. You're nuts. When I'm first just understanding it. But I'm open-minded. It's $5 a bottle. I gave it to 3 people. So the first person had a liver transplant, had carcinoid relapse, had liver transplant. One of the most complex patients because she was on immunosuppressants. Very complex, but highly educated, very knowledgeable of her disease. And I just threw it. The first one, I just threw it at her. And the next, within a couple of weeks, she said, yeah, it worked. And I'm sitting there saying, no, you're not. You're crazy. Now, I knew she wasn't, but in my mind, saying, "Oh, it's just at random." Maybe it did, maybe it didn't. So did another one, same thing. Now, the next case wasn't as complex. By the third time in a row, 1, 2, 3. Okay, I said, "Oh man, when something like this happens to you, your work is cut out for you. You can't step back from it. Now you have to chase it. If only one out of those 3." Accepted, I'd probably say, okay, I was right. I put this to bed, never hear from it again. Not the case. So I said, okay, we had some opportunities to create a clinical trial retrospective where we would take patients who would have 4 more bowel movements a day for a month or so, and this data set collected from August 17 to June of 18, and we just gave these people about a case or 2 of this agent, medical food. They took 1 bottle twice a day. They reported back to us. That's all we asked them to do. No blood collection, no stratification, no randomization or something. So we did 75 people within less than a year. And we got pre- and post-treatment diarrhea data on 41. So you can kind of tell when you don't have a clinical trial team in place, about half of them don't take you seriously, and you gave them product. And you can't go after those people, right? You can't go, I'm going to sue you. No, just kidding. So anyway, the mid-guts are 18. You can see how they're all listed there. The number of bowel resections, about half. Somatostatin receptor analogs, about more than half. 33 out of 41 said they were improved. Well, when you look for the rigor of clinical trial, what does that mean? We don't know. Well, we can try to say, well, at least half, 19 out of 33, more than half, experienced at least a 50% decrease. Well, maybe that meant something. So we concluded with this retrospective, single-center, non-randomized, non-scientific, you may say hypothesis generating, that's all we did, concept of where 80% of these patients improved, 57% reported more than 50% reduction, and so that launched us into a prospective clinical trial, just like Dr. Fine. Instead of being therapeutic with capecitabine temozolomide, now supportive care. We can improve people's quality of life with diarrhea management, control costs, and improve quality of life. We've made some advancements. So that's where we are. You go to clinicaltrials.gov. This trial is listed. It's open. It's going to be open at Vanderbilt probably within the next month. So this is a real opportunity for us to take an idea that started with listening and reading the scientific literature, communicating with the people doing the work, seeing that it was very believable, testing it, seeing that it worked in a small group, and now putting it up against, you might say, the tough world. It's going to be the tires are going to be kicked, and we'll see how good it is. So what this trial is there has to be a net diagnosis and more than 4 stools a day, and we have two cohorts. One group has the syndrome, one does not, and there's a control period, 28 days. Just take a diary, you just document that you've got the problem, and then you go through a 30-day period No random, you own the product. No blinded stuff here. You own the product. And then 30 days after that, we see how fast it comes back. How good was it? What's the duration of the effect? That's it. Okay, what's coming next? Radiolabeled somatostatin receptor antagonist. We use the agonist. The antagonist does not internalize into the cell. I know this is a little bit complex science, but this is what's coming next in the world of PRRT. Immunotherapy. If you're not doing immunotherapy, then in the world of medical oncology, you're being left behind. PRRT with immunotherapy, PRRT with radiolabeled embolization, even though Dr. Doss and myself probably aren't personally doing that. That's a very tricky area, combining two forms of radiation that is going on out there. PRRT with VEGF inhibitors, mTOR inhibitors, these are all synonyms and acronyms I don't expect you to know, but things that are just to show you that this is a very busy space of research. We know that no two of you are alike, and it's the pattern of the zebra stripes. No two of them are alike, and therefore there should be no two patients should be treated exactly alike. So this is where the complexity of walking down this maze is hard for the patient. It's also difficult for the physician that doesn't specialize. We'll stop right there. Thank you.
Well, thank you, Dr.